Welcome to this StudyNeuro lecture on brachial plexus injury treatment, where we'll take you through the journey from acute care to rehabilitation. In this session, we'll explore how early recognition and accurate assessment of these injuries guide effective treatment, discuss the different types of nerve damage, and highlight when surgical intervention is needed. You'll also learn about key surgical techniques, from nerve repair and grafting to nerve transfers and secondary procedures, and understand how structured rehabilitation helps restore movement, strength, and daily function. Finally, we'll emphasize the role of a multidisciplinary approach in achieving the best long-term outcomes. By the end of this lecture, you'll be able to apply these principles to optimize care and recovery for patients with brachial plexus injuries. For more in-depth neuroscience lectures and clinical insights, be sure to follow us at youtube.com/StudyNeuro. The brachial plexus is a vital network of nerves that controls both movement and sensation in the upper limb and upper chest. It's what allows you to coordinate complex arm movements, generate strength, and perceive touch, temperature, and position. Injuries to the brachial plexus can vary widely. Some are mild, like neuropraxia, while others are severe, such as complete root avulsions. The extent of injury directly affects motor function, sensory perception, and ultimately long-term recovery outcomes. Because of this wide spectrum, timely evaluation is essential. Early assessment helps distinguish injuries that require urgent intervention from those that can be managed later. It also identifies patients who might benefit from nerve reconstruction or transfer, improving the chances of meaningful recovery. Managing brachial plexus injuries focuses on helping patients regain movement, reduce pain, and prevent further nerve damage, all while aiming for the best long-term recovery. The approach depends on the nature of the injury, whether it's a simple stretch, a tear, or a complete root avulsion, and whether it's an open wound or closed. Catching these injuries early is key because delays can limit the success of surgical repair. Treatment follows a structured process, first stabilizing the patient, then performing detailed diagnostic tests, and finally planning reconstruction when it's most effective. This stepwise approach ensures nerves are repaired at the right time, giving the best chance for meaningful recovery. When someone suffers a brachial plexus injury, the first step is always to make sure they're stable and address any life-threatening issues. High-energy trauma can bring multiple injuries, so protecting the arm and managing other fractures or vascular problems is just as important as assessing the nerves themselves. Pain is often a major concern. Nerve-related pain responds best to medications like gabapentin or certain antidepressants, while pain from tissue injury may require anti-inflammatories or short-term opioids. In severe cases, targeted nerve blocks can help, but they need to be used carefully early on, before the exact extent of the nerve injury is clear. How we treat a brachial plexus injury really depends on how the nerve was damaged. When there's an open wound, surgeons often need to look directly at the nerve to see whether it's completely cut or still intact. If the nerve has been sharply severed, repairing it as soon as possible, ideally within a few days, gives the best chance for the ends to reconnect without tension. Blunt injuries, on the other hand, benefit from a short waiting period to let scar tissue stabilize before repair or grafting. In some open injuries where the nerve hasn't been cut, careful monitoring over time is usually enough. For injuries without an open wound, most nerves remain connected and recovery often happens naturally. Doctors watch closely with exams and tests to see if the nerve is healing. If there's no progress after a few months, surgical exploration may be needed. During surgery, nerve signals help decide the best approach. If signals are absent, the damaged section is removed and repaired. If signals are still present, a simpler procedure to free the nerve may be enough. Management of brachial plexus injuries depends on their severity. Neuropraxia, the mildest form, usually recovers on its own with observation, physiotherapy, and pain control. Axonomesis, a moderate injury where the axon is damaged but the sheath remains intact, is monitored closely, with surgery considered if reinnervation hasn't occurred after a few months. Neuromesis, a complete disruption of the nerve, typically requires early surgical repair or grafting, with timing depending on whether the injury is sharp or blunt. In the most severe cases, such as root avulsions, nerve or tendon transfers are often necessary, and early rehabilitation is essential, though full recovery may be partial. Many brachial plexus injuries can be managed without surgery, especially in the early stages. Gentle physiotherapy helps keep the shoulder and elbow moving and prevent stiffness, while avoiding heavy strengthening until the nerve shows signs of recovery. Occupational therapy is also important, helping patients adapt to everyday tasks and using splints when needed to prevent hand or wrist deformities. Often, mild stretch injuries improve on their own within a few months. If recovery isn't progressing as expected, doctors may then consider surgical options. Surgery is considered for brachial plexus injuries when nerves are completely torn, roots are avulsed, recovery stalls after a few months of therapy, or symptoms like pain or weakness worsen. The main goal is to restore nerve continuity and regain muscle function. Depending on the injury, surgeons may free scarred nerves, perform direct end-to-end repair, use nerve grafts to bridge gaps, or redirect healthy nerves through nerve transfers to reinnervate affected muscles. When nerve recovery is incomplete or delayed, secondary procedures such as tendon or muscle transfers, joint fusion, or functional muscle transplants can help restore movement, improve stability, and optimize long-term function. Neurolysis is used when a nerve remains intact but is surrounded by scar tissue. The goal is to remove this tissue to improve the nerve's environment and support recovery while preserving its structure. Nerve stimulation during surgery helps confirm that conduction is preserved, which predicts good outcomes. Nerve grafting is needed when a nerve segment is completely disrupted, but the proximal stump is healthy. Achieving a tension-free repair is essential, with shorter grafts generally giving better results. Common donor nerves include the sural, medial antebrachial cutaneous, and ulnar sensory branches. The main goal is to restore functions like elbow flexion, shoulder abduction, and forearm sensation, though longer or distal grafts tend to have poorer outcomes. Neurotization, or nerve transfer, is used when proximal nerve roots are irreparably damaged, such as in root avulsions. The principle is to redirect a functioning donor nerve to reinnervate a denervated muscle and restore useful movement. Donor nerves may come from within the brachial plexus or from outside it. A common example is the Oberlin transfer, where a small ulnar nerve fascicle is connected to the biceps branch to restore elbow flexion, often producing good functional strength when the lower plexus is intact. Other options include spinal accessory, intercostal, phrenic, or cervical plexus nerves, each selected based on injury pattern and functional goals. In severe global plexus injuries, a contralateral C7 transfer may be considered when donor options are limited. Secondary procedures are used when nerve recovery fails, deterioration continues, or patients present late after injury when primary nerve repair is unlikely to succeed. In these situations, the goal shifts from reinnervation to restoring useful function and stability. When nerve recovery isn't possible, the focus shifts to reconstructive strategies that improve function and stability. Non-neural options such as joint fusion can provide a stable shoulder, while tenodesis can enhance hand function through passive or synergistic movements. Dynamic reconstructions, including tendon and muscle transfers, use functioning muscles to restore key actions like shoulder abduction or elbow flexion. In more advanced cases, Functional free muscle transplantation can help restore elbow or finger flexion and significantly improve overall limb function. Recovery after a brachial plexus injury depends heavily on rehabilitation, and it's a process that starts immediately and continues well beyond surgery. The goal isn't just healing the nerve, but translating that healing into real, usable movement. Early on, therapy focuses on keeping joints flexible and protected. Gentle movement prevents stiffness, while proper support of the shoulder helps avoid subluxation. Managing pain at this stage is essential because uncontrolled pain limits movement and slows recovery. As nerves begin to recover, rehabilitation becomes more active. Therapy targets muscles that are starting to re-innervate using guided techniques to help patients activate them early. Functional training then helps turn these gains into everyday skills like reaching, grasping, and self-care. Rehabilitation also changes depending on the type of surgery performed. After nerve repair or grafting, movement is introduced gradually to protect healing tissue and retrain new motor pathways. Nerve transfers require patients to relearn how to activate muscles using new control signals, while tendon or muscle transfers follow a structured progression from protection to strengthening and functional use. Throughout recovery, supportive devices such as splints or adaptive tools can significantly improve independence, particularly in more severe injuries. In conclusion, the key to recovery from brachial plexus injuries lies in acting early, choosing the right intervention, and maintaining consistent rehabilitation. Recognizing the injury quickly and understanding its severity shapes treatment and expectations. Timely surgical repair or nerve transfer boosts the chances of meaningful muscle recovery. Focused rehabilitation helps patients regain strength, movement, and independence. Protective measures prevent stiffness, pain, and long-term complications. Collaboration among surgeons, therapists, and care teams maximizes overall outcomes. Thanks for watching. Don't forget to like, share, and subscribe to StudyNeuro for more clear, high-yield neuro content every week. Share your key takeaway below and stay tuned for more neurosurgery made simple.